Today, I'm going to present this talk. Draulio is a professor at the Brain Institute at the Federal University of Rio Grande do Norte in Natal, in Brazil. Since 2006, he's been exploring the basis of acute and lasting effects of ayahuasca using different tools such as fMRI and EEG in both healthy individuals and patients with treatment-resistant depression. So, welcome very much.
Well, first of all, thank you to the organizing committee for having me here. So it's a pleasure and a great opportunity to speak a little bit about these almost 20 years that we have been dedicated to studying psychedelics. And I'd say in two main routes. First route is to understand the effects of psychedelics in the human brain. So our group is mostly dedicated to human neuroscience, as well as to conducting clinical trials with ayahuasca first, and then, as you can see, for the past about 5 years, we have been working with N N-Dimethyltryptamine, isolated N N-Dimethyltryptamine. This story then begins as in 2006. There we go. So this story begins in 2006. My background is in physics. So I did all my training in physics and then applied physics. During my training, PhD and postdoc, I was basically developing, that's back in 1998. I was developing methods to different types of functional neuroimaging, mainly fMRI, EEG, and MEG. So in 2006, I basically defined these tools to understand different cognitive processes. And then one of these processes that we became interested in was to understand the acute effects of ayahuasca. As some of you might know, ayahuasca is an indigenous invention that brings together two different plants from the Amazon region. One of the plants is rich in N N-Dimethyltryptamine, which is a very psychedelic substance that brings a lot of psychedelic effects. But N N-Dimethyltryptamine, if you inject it, it's going to get oxidated by enzymes that we have in the gastrointestinal system called monoamine oxidase. And by some way, the indigenous populations from the Amazon found out that when they mix two plants together, one rich on N-DMT and the other one rich in monoamine oxidase inhibitors, it allows DMT to enter into the blood circulation and bring a psychedelic effect that lasts for about 4 to 5 hours. This substance is used throughout in South America by different indigenous populations as a sacrament. I wouldn't say a sacrament, but as a formal basis of their religious culture. In the 30s, so since May 1930, ayahuasca has been started to be used by different religions, urban religions, mainly 3 religions in Brazil. They're called the Santo the Vegetal, and the Alquimia. These 3 churches, and the first church gathered for the first time in May 1930, and they used ayahuasca as their main sacraments. And that was our first line of studies, was to try them to investigate using one of these tools, or basically 2 of these tools, EEG and fMRI, to understand the neural basis of the acute effects of ayahuasca. In order to do so, basically, we recruited individuals with a lot of experience with ayahuasca from one of these churches close to our university hospital, and we brought these individuals into the hospital and had them doing a couple of MRI scans while they were under the influence of ayahuasca. These are the first, then we basically were focused on. Okay.
Sorry, the people on Zoom are saying that there is a problem hearing from the microphone to move far away from the picture.
Okay.
So it would be possible to.
Sure, yeah, no problem.
Thank you very much.
Sure, yeah. Here is good? Hello, here is good? Okay, all right. So, good. So the idea here then was to understand the acute effects of ayahuasca, and we were interested in mainly three main acute effects of ayahuasca and psychedelics in general. The first one is the idea that these substances bring about a lot of visual experiences, mental imagery experiences, that by a stretch, it's been called hallucinations. And why I say it by a stretch? Because hallucination is something that generally you have it represented in our physical world. Most of the visual imagery that happens during psychedelics and during ayahuasca happens with your eyes closed. So if we were to compare a physiological event that resembles the mental imagery experience that you have under ayahuasca or under psychedelics, maybe dreaming would be a better example. That you have very complex images that can range from fractals, colored images, to speaking to someone that you don't even know, just like a dream. So in this first set of experiments, we were interested in understanding then the neurobasis of the visual effects of ayahuasca. This is one of the publications in which we show on the left, in the top row, you see our occipital cortex. In the middle row, you see the temporal cortex, the medial temporal areas. And in the bottom row, you see the frontal areas. So the main results of these experiments show that, and this gives the name of the paper, Seeing with the Eyes Shut. So the idea here is that we were starting to understand that the effects of ayahuasca for the visual system has a profound impact on our visual system that comes along with recruiting a lot of our visual cortices, including the primary visual cortex. This is what you see on all the two main rows, two first rows. These blue shadow areas represent the retinotopic mapping that we did in this experiment. So to localize where V1, V2, V3, V4, and V5 is. So what you see on the topmost and on the second image is that BA17, which is the primary visual area, seems to increase its activity during the acute effects of ayahuasca. We have a lot of medial temporal areas like the parahippocampal gyrus, the hippocampus, and a little bit of the amygdala. And on the bottom, you see a lot of the frontopolar cortex. So bringing the idea that, especially this last row here, one thing that's it's very interesting is that later on, it became clear that lucid dreaming, for instance, recruits a lot of this frontopolar area that we also saw under the influence of ayahuasca. The second effect that we were interested in investigating is the increase in introspection. That is, the increased ability that we gain in understanding or being aware to our own thoughts and our own emotions. And basically, this comes with what is becoming a very standardized result in psychedelic research, which is the recruitment of the default mode network and the recruitment of the salience network. So here what you see is an increased activity of the salience network and the decreased activity of the default mode network under the influence of ayahuasca. The third result we got, so here I'm just bringing a few of these main results we had in these first line of experiments. On the left, you see a brain under placebo. On the right, you see a brain under ayahuasca. And this is also becoming a very general result that we find in psychedelic research during the acute effects of psychedelics, which is an increase in entropy. That is an increase in the number of connection that the brain can have between two different areas. So that you understand a little bit of this representation, each point you see in the circle represents a specific brain region, and each line represents a functional connectivity, a significant functional connectivity between two different regions. And what we see is that on the right is that under the influence of ayahuasca, there is an increase in the number of connection. That is, there is an increase in the level of disorganization that the brain has. When we were doing this study, as I said, we went to this Santo Daime church to recruit experienced individuals, to have people with a lot of experience inside an MRI scanner. As some of you might know, the effects of ayahuasca are not trivial. They're very strong. They come a lot with vomiting, some diarrhea, and nausea. So we usually want to have someone throwing up in a scanner, in a hospital scanner. So basically what we had is the idea of having experienced individuals for all of these experiments. When we were doing this, then it became clear that the people that were in the church, they were not there exclusively for ritual purposes. A lot of the people, they would spontaneously come to us and say, well, I'm here because I got better from a very severe depressive episode. I'm here because I had a very abusive use of alcohol. I had a very abusive use of tobacco. I had a very abusive use of cocaine. I had post-traumatic stress disorder. So it became clear that there was part of what we were seeing there was a really therapeutic effect of ayahuasca. That was back in 2008 when we decided to conduct our first clinical trial with ayahuasca, which had in our university hospital. But in that case, all the subjects had no experience with ayahuasca. So 100% of the patients with depression, they were naive to ayahuasca. That was their first experience with ayahuasca inside a hospital. The first study then that we had was an open label study with 17 patients. What you see on the left are the clinical results. What you see on the right are SPECT images that we've taken 8 hours after the intervention. I want to call your attention to the blue line and the orange line that you see on the graph on the left. These two lines, they represent the two main clinical scales that we use to assess the severity of depression, MADRS and the Hamilton scale. What you see then, you see that the graph has a break on it. So for the left, and this is 10 minutes before intervention, 40 minutes after intervention, 80 minutes, 140 minutes, 180 minutes. This is 1 day after intervention, 7 days after intervention, 14 and 21 days after intervention. So what we see here is a clear and significant decrease of the depressive symptoms in these patients. They were all treatment-resistant depression. Treatment-resistant depression is a psychiatric definition. It's basically patients that have tried at least 2 different antidepressants and who have not responded to these 2 different interventions. And then what you see is a rapid antidepressant effect of ayahuasca already in the session, but very clearly in the days following the sessions, 1 day after, 2 days after, 7 days after, 14 and 21 days after. On the right, it's a SPECT scanner. And on the SPECT scanner, we had 8 hours after the session. And what you see is an increased blood flow in 3 areas that are well known related to mood disorders: the nuclear accumbens, the insula, and the anterior cingulate. And what you see is part of what could be the results for the significant antidepressant effects of ayahuasca. With these promising results, we moved on to a randomized placebo-controlled trial. You've met Fernanda. Fernanda was here, I guess, last year presenting these results. But this is then the randomized placebo-controlled trial. 35 patients with depression, half under placebo, half on ayahuasca. And again, what I'm showing here is one of these scales, the MADRS scale, to assess the severity of depression. You see in red are the ayahuasca group, in blue is the placebo group. So here you see a consistent rapid antidepressant effect of ayahuasca already 1 day after the session. a significant placebo effect. And it's too bad that you cannot see this part. But then 7 days later, the placebo effect just vanishes, the results, and then you have a standardized and linear effect of 7 days after the intervention. We also try to understand the origin of these effects. So we have a number of papers published trying to understand where the antidepressant effects of ayahuasca came from. So in order to do this, basically what we have done was to collect a lot of data before and after the intervention. Before, so we collected blood, saliva, MRI, EEG, polysonography, and different scales. And what you see here is basically a machine learning strategy that we used out of these 24 biochemical markers that we used. We tried to understand which were the ones that were most significantly involved in the antidepressant effects of ayahuasca. And we found 3. Cortisol seems to be impacted by the effects of ayahuasca. C-reactive protein, so stress with cortisol, inflammation with C-reactive protein, and brain-derived neurotrophic factor, meaning that we found an increase in BDNF after the intervention in these patients. So these were the 3 main biomarkers that we found to be significantly related to the antidepressant effects of ayahuasca. That's not to say that the acute effects of ayahuasca, the subjective effect of ayahuasca, did not have an impact. It also had an impact. So what we found is that the effects of ayahuasca, the antidepressant effects of ayahuasca, they come about through 2 different routes. The first route is a clear biochemical route involved with stress, involved with inflammation, and involved with neuroplasticity. The second one is related to the acute effects of ayahuasca. So we did find a significant correlation between the changes in visual perception. So people who reported the most significant change in visual perception were the ones who found the most beneficial therapeutic effects of ayahuasca. So it seems, for the results that we have, that this is twofold. On one end, we have the biochemical importance of ayahuasca as a homeostatic, almost homeostatic kind of input in our biological system, but the experience also matters, it seems, to me. So with that in hand, we know that, as I said before, that ayahuasca is a mix of 2 plants. On the left, on the right, on the left, you have the DMT, which is an endogenous tryptamine. Very curiously, DMT is present in many different species, living species. It goes from different animals, different plants, different fungi, and including humans. So all of us, while we speak right now, we do have very little, but we do have circulating amounts of DMT in our body right now. As I said, dimethyltryptamine, as any tryptamine, is going to be destroyed by enzymes we have in our gastrointestinal system. And these are some of the molecules presented on the other plant. The monoamine oxidase inhibitors like harmine, harmaline, tetrahydroharmine. These 3 molecules, they prevent DMT from being oxidated by these enzymes. So it inhibits the action of these enzymes, and then it allows DMT in our blood circulation, and then it allows DMT in our central nervous system, and then it allows all the complex effects of ayahuasca. The point here is that the effects of ayahuasca, they last for about 4 to 5 hours. And it was, if we put together, if we have a summary of what we have found in these years from 2008 to 2018, that's when we published the randomized placebo-controlled trial, it became clear that although we had a very interesting result, very significant antidepressant effect and the rapid antidepressant effect, I'm going to go into these terms a little bit later, but we did find that one day after the intervention, there is a significant decrease in depressive symptoms of these patients. But we understand that part of our goal is to test and try to implement psychedelics for clinical use. So this is part of the mission that we have been pursuing for these past several years. And when we had these results on one end, we found something interesting and clinically relevant. But on the other end, what is the applicability of ayahuasca in clinical terms? We already know that from the FDA MDMA issue that just went on in August, it's very clear that price is something that the psychedelic community who understand the clinical value of psychedelics, this is something we have to think about. I mean, MDMA is supposed to cost 22,000 grand per patient. That's not a solution. Sure, $22,000 per each patient, that's not a solution. And in part, that's because the protocol is long, it involves a lot of people, the effects of MDMA is complex and long. So that's when, 2018, we decided to switch gears in the lab. So we're not doing any more research with ayahuasca, and we switched to DMT, isolated DMT. So this is what we have been focused for the past 5 to 6 years, is to understand, again, the neurophysiology related to DMT and also the clinical possibility of using DMT as an antidepressant. So in order to do so, and there were many reasons why we decided to go with DMT, but one of them is the fact that DMT is found in abundant quantities in this tree that's called the Mimosa tenuiflora. The Mimosa tenuiflora is commonly known as Jurema preta, is a tree that grows naturally in Brazil, is endemic in Brazil, especially in the northeast of Brazil, in the dry lands of Brazil. That's where we are. So the Brain Institute is located in the northeast of Brazil, which is one of the poorest part of the country. And in the dry lands of this part of the country, we have huge amounts of Mimosa tenuiflora. The Mimosa tenuiflora was explored by this Brazilian chemist called Oswaldo Gonçalves Lima. And this guy was the first scientist to find DMT in the living species, which was in the Jurema. And it's funny because now we are contemplating the fact that DMT is present throughout living nature. This was the first example of a sample of DMT being found in the northeast of Brazil. So this guy comes from one of the state that's right next to the state where we are right now. He found it, he named it, he thought he had found a different molecule. He named it nidgerine. And then a few years later, when he sent samples of nidgerine to the United States, then it was found that it was not nidgerine, it was DMT, which had been synthesized in 1931. So with this, we then got all the approvals for the Brazilian government, and now we're able to produce our own sources of DMT from the Mimosa tenuiflora. So the first years, we spent understanding some of the chemical aspects and pharmacological aspects related to DMT. So we dedicated ourselves to the process of extraction, purification, and characterization of the DMT from the Mimosa tenuiflora. This is the characterization that we have from the DMT that we have been now extracting, characterizing, and we have characterized it with different analytical chemistry techniques. Here you just see a few of these showing that we do have a high purity DMT. This is the DMT. This is all from the lab. So this is, we are now capable of getting a 99% purity DMT. These are the crystals of DMT we have. This is some of the different parts of the plant because we also wanted to understand where in the plant it was the richest source of DMT. It's very clear that it's in the roots. We have a couple of research projects trying to understand the biosynthesis of DMT in the Jurema. So we are about to publish the genome of the Jurema, the metabolome of the Jurema very soon. And the reason why we want to do it, because we want to understand what is the biosynthesis route of DMT in the plant. We also have a number of projects that try to understand if the production of DMT by the plant varies throughout the year. So we had a number of experiments going on to understand if these concentrations of DMT, they change along the year. It seems that it does. So when the plant is most stressed, it is when it produces the largest amount of DMT, and the largest amount of DMT, independently of when you collect it, is in the roots. So in the root bark, that's where you find the largest amount of DMT in the plant. So with the authorizations and with the possibility of having our own DMT, we started the preclinical trials with DMT, and we had to choose the route of administration of DMT. Most of the studies with DMT that are going on right now, they use an intravenous route of administration. We decided not to go through an invasive route. And the reason here is to understand that maybe if we do not go through an invasive route, that could give access to DMT to different professionals. If we go in an IV route, that means that you need a physician. If we go in a vaporized route, maybe not. So here what we have is how we have been using DMT in a vaporized form. So basically what we have those metallic meshes that you see on the left. On those metallic meshes, we basically dissolve DMT on alcohol, and then we spread alcohol with DMT on that mesh, let it evaporate, and then we have DMT homogeneously spread throughout the mesh. And then we warm up this mesh to 200 Celsius. It produces a vapor of DMT, and then the individuals inhale that vapor of DMT. The first study then was to understand the safety and tolerability of DMT in small animals. So, I don't have this here, sorry. Jesus, I'm sorry. Well, we do have a number of experiments that are going on with small animals to understand safety, tolerability, and LD50. One thing that's very neat, we just had a result in which we did not find an LD50 for a model of fish that we have. Do you know what LD50 is, right? The lethal dose. So the lethal dose, the dose that kills 50% of your sample. So this is the toxicology measurement. For ayahuasca, that's very clear. We do have an LD50, but for DMT, we couldn't find an LD50 so far. So now we are running a second batch of experiments, increasing DMT concentration to sky-high levels. Here we are already talking about 100 times the typical dose of DMT. So we're going to escalate that to about 1,000-fold to see if we find the LD50. Anyways, with this, then this is our clinical setting in the hospital. This is a waiting room. This is where we have the DMT session. So it's basically a living room, very comfortable, with a few clinical measurements like blood pressure, heart rate, respiratory pressure, temperature, and so on. So we are capable of measuring all these effects. So, and then the good thing about DMT in a vaporized form is that instead of 4 hours of experience, for the vaporized DMT, that lasts about 10 to 12 minutes. So in 12 minutes, people, they have their full psychedelic experience. So that speaks a little bit about the feasibility of having this inside the clinical setting. As an intervention, for instance. So we have, okay, so it's not going to play, but anyways, so that you know, we have a artist that works with us, Raphael Eagle. He's actually from Germany. And he's been composing the songs that we are playing throughout the, that's his website, and all the songs are in there. So he composed basically 6 different songs for the trial, specifically for the trial, 10-minute long song, which we played in the randomized order. So this is the first dose response study that was published on January this year. Basically, we tested, as we didn't know what's the dose for the transfer function, right? So we tested a number of different doses, and this is basically the protocol we are using. So first, we have a very careful screening. Our screening tends to last about 1.5 hours to 2 hours. It's done by a psychiatrist. We have a number of psychiatrists in our group. And then one day later, we have what we call the preparation, which is done by psychologists. So we do have a group of psychologists in our research team. That happens before the intervention or before the dosing session. The preparation, the screening happens between 2 weeks at most before the dosing session, and then the preparation at least 2 days before the dosing session. And black, you see the dosing session, and one thing that's, which is something that we have implemented in our protocol, is that we do have 2 inhalation in the same dosing session. So that's what you see 5, 20, 7, 5, 30, 4 times, is that the first dosing in the dosing session, the first inhalation happens with 5 milligrams, then we wait for 2 hours. DMT does not show large tolerability. In fact, as you see in the PK curves, very soon, 15 minutes, it's already hard to find any circulating amounts of DMT after the inhalation. So then we have 2 dosing sessions, 2 inhalation sessions in the dosing session. So session 1, then we collected a number of measurements, the subjective experience through scales, physiology, like I mentioned, temperature, heart rate, blood pressure, and so on. Biochemistry, so we collect blood for PK and also for all these biomarkers that we have been interested in, and adverse events. So we measure that twice, after the low dose and the high dose, session 1 and session 2, as you see here. After the second dose, well, after the 2 doses, we do have an immediate integration, which is basically a conversation between the subject and the psychologist, the same psychologist that did the preparation session before. Then one day after the session, we do have again an integration session, a number of psychology questionnaires. Then day 2, psychology questionnaires, day 7. Then day 14, they come back to the hospital. That's when they have the medical follow-up to collect for adverse events and all that. 14-day integration, another set of psychological questionnaires, and then day 28 is when they got dismissed. That's when we have the feedback from the protocol and another group of psychological questionnaires. This is the PK, as I mentioned. So you see that's the low dose, this is the high dose, this is the 1560 dose, which became the dose that we have chosen as a good tolerability and safety measurement. But you see that in about 10 minutes, there is already a significant 2 minutes is the peak for both physiology and the PK. And then 10 minutes after the intervention, you see that the levels of DMT are already low. This I find very interesting for the understanding of clinical applicability, because this speaks about how safe that intervention can be. First, DMT is endogenous, and we do see from this graph that our body is very prone to degrade DMT. And it does it in a very efficient way. When we compare to LSD, for instance, at 12 hours, you already have traces of LSD. This already speaks a lot about the safety of DMT. And we'll see that that has some clinical implication in the trial, in the follow-up trials. These are some of the physiology responses that we have. So heart rate, respiratory rate, peripheral blood saturation, temperature, and blood pressure on top. So you do see that there is a significant increase in blood pressure, heart rate, mainly. Although it's significant, it does not go beyond the safety boundaries. So what I'm saying here is that the highest heart rate that we found goes to 130 beats per minute. 130 beats per minute I probably had when I scaled up the stairs. So a very mild exercise, you're going to get to 130 beats per minute. So it increases, but it rapidly decreases. So you see that in about 15 to 18 minutes, it's already back to normal, to what it was before. No significant impact on the respiratory rate. This is very important because by this graph here, we understand that respiratory deprivation is not something we should expect with DMT, which is very common in some substances that are being used right now, like ketamine. So one of the risks of ketamine is respiratory deprivation. So this is where people die from. In an overdose, for instance, is part of the issue. So no significant impact in oxygen saturation, no significant effect on temperature. So effects on heart rate and blood pressure. With that in hand, then we moved to the next step, which is an open label trial with patients with depression. This is Rafael, so that you know. This is the trial. So we were really trying to control for some of the influences that we see in other trials. For instance, very few of our psychiatrists have a prior experience with psychedelics, and just 1 out of the 14 patients had a previous experience with psychedelics. So this is not an exclusion criteria, having a previous experience with psychedelics, but we try our best to recruit patients who do not have a previous experience with psychedelics, just that we understand that clinically, if we want to have something that's clinically widely used, most of the people won't have a previous experience with psychedelics. So it's how someone who does not have an experience with psychedelics will deal with the experience, will find it safe, will find it tolerable, and so on. Again, these patients different, and this is something I want to comment on because on the first study, on the phase 1 study for safety and tolerability, all subjects had a previous experience with psychedelics, but that was out of security measures. It was our first experiment with inhaled DMT. We wanted people who had previous experience with DMT. We were not looking for a therapeutic effect. We were looking pretty much for a safety and tolerability profile of DMT. So all of the individuals had a previous experience with DMT. And that is interesting because when a healthy individual comes to the lab for a DMT experience with a previous experience with DMT, they want the experience. A patient doesn't want the experience. A patient wants to get better. They don't care about the experience. And this is something we have to keep in mind because we have to come up with solutions for people who doesn't care about the experience. And we need to provide a safety environment and a safety experience to these individuals. So this is the clinically relevant data. And the second thing I want to point out here is that for the studies with ayahuasca, there is a theoretical risk that people under serotonin inhibitors, they might have what you call a serotonergic syndrome. And that is very dangerous. That could be lethal, potentially lethal. So with that, in our studies with ayahuasca, all of our subjects, they went through a washout period of 2 weeks. So in other words, we removed all the medications 2 weeks before the intervention with ayahuasca, and 12 days into the washout period, we did a single intervention with ayahuasca. In this case, after we saw the profile of DMT, we decided not to recruit only patients with TRD and not to do a washout. So on this trial, we don't have a washout. The only thing we have is that in the day of the dosing session, patients should refrain from their medication. But on the following day, they can just have it again as part of their routine. So that means that's what we are calling PRD or TRD. PRD is partial response depression. Partial response depression is another term from psychiatry and basically means if you are in your first treatment and you're not responding to the treatment, you're already partial responding depressive. For TRD, you have to have tried at least 2 different medications at the adequate dose. And that is an important thing because with that design, we might think of this type of intervention as an adjuvant therapy. So it's something that you do not, it's something that you could use together with your traditional treatment. And this is what we tested from safety measurement. This is the protocol. You see that the protocol it's similar to the one. The difference here is that the follow-up, it goes to 3 months. So in 3 months, we have another follow-up that's not here. So you see that's very similar. The difference here is that we've chosen a specific dosing scheme. So in other words, the first intervention, the session 1 is with 15 milligram and session 2, 60 milligram fixed. So we did not vary this as we did in the phase 1. Then we evaluated wherever you see MADRS and PHQ-9, those are the 2 evaluations that we're using for depression. The MADRS is applied by a psychiatrist and the PHQ-9 is applied by the patient. So it's basically a self-report, 100% self-report, and a third eye report from the patient and from the psychiatrist. We do have a number of psychological integration. We have an immediate integration after the 2 interventions, after session 1 and session 2. And we also have a number of psychological integration that goes all the way to day 7. And then we do have a few medical follow-ups for adverse events and so on, up to 3 months. These are the first-hand results. This has just been submitted a couple of weeks ago. And basically, what I'm reporting here are on the left, you see the MADRS scales. You see the zones for severe, moderate, mild, and no depression. You see that most of our patients, on average, they were moderate to severe before the intervention, that's what you see in the first points. And then 1 day after intervention, 7 days after intervention, 14, 1 month, and 3 months after intervention. This is response rate and remission. Response is basically a variable that relates to the fact that the number of individuals that have a 50% reduction on their depressive symptoms. So this is counting the number of people that has it. And then remission are the number of patients who do not have depression or do not have the scores for even mild depression. You see that the response rate and remission rate, they vary between 75 and 80% at day 1, and then 80-some% response day 7, day 4. And then at month 3, we still have 40% of remission and about 60% of response rate. That's after a single intervention using that protocol. One thing then that I want to point out and stress a little bit is the fact that we do have a result which is interesting for the fact that it is showing a promising antidepressant effect. That's the first message here. But the most important message here is the fact that we find it to happen 1 day after the intervention. And why is that important? Because every antidepressant that we have on the market today, we have to wait for about 3 weeks in order for that antidepressant to have an effect. And that is very significant, particularly in patients with a high suicidality index, because And we know that when you're changing medications, those 2 to 3 weeks when you're changing medication becomes a very critical period in which the patient can use that energy that it didn't have to commit suicide. So a lot of the suicide happens when you're doing changes in medication just because of this. And we do not have a lot of alternatives for an intervention that will bring about a rapid effect, which would be something desirable for someone with a high level of suicidality. So that's why we decided to delve into the suicidality of these patients, so the level of suicidality of these patients. This is what you see there from one of the MADRS scores. So this is how suicidality reduced. But I want to stress and point out the second graph here, which I find the most beautiful result we get from this phase 2 trial. And this is, if you look at, we basically stratified the patients into severe suicidal ideation, no suicidal ideation. You see that only about 15% of the patients had no suicidal ideation. And we have about 45%, 35 to 40% of the patients who had a high risk of suicidality. This is before. But look at what happened one day after the session. One day after the session, no severe suicidal ideation at all. And that number, so if we look at the black line, that speaks very clearly about the potential of having an intervention that reduces directly the suicidal ideation of these patients, bringing the idea then that you could think of this as an intervention, as a psychiatric intervention of patients that are high risk, for instance, for suicide. So this is where we are. I basically did a road tour from 2006 to 2024 when we started our fMRI studies, and now with the DMT intervention. And we've just then created the Center for Advanced Medical Psychedelics. And the center, it's born with a goal. So now that we have these interesting results for the phase 2 clinical trial, we want to move into the phase 3 clinical trial. So we are right now putting together everything we need in order to run a phase 3 clinical trial in a multi-center in Brazil. Probably you don't know, but Brazil has the largest public system in the world with about 220 million potential clients, which is the Brazilian population. So the idea here is to bring DMT into this public health system in Brazil through depending on the results of the phase 3 clinical trial. So right now we are putting together this phase 3 clinical trial for the vaporized DMT in patients with depression as an intervention for depression. So in conclusion, I just want to thank this large group of people. This is part of the center. So we do have a lot of psychiatrists here. We do have psychologists. We have nurses. We have biologists. We have computational neuroscientists, and so on. With that, I'd like to thank you again. I guess I'm on time. So thank you for the invitation and congratulations for the series.